Hello friends, it's so nice to meet you again in this video. Uh, Thanks for all of you who have actually commented and wrote and asked about the previous videos. I think this one will be the most important part of my talk about pain management, the most important. And I believe that everybody should follow the scheme which I'm going to outline. It's important because it involves the assessment of pain, which is a very important step in actually treating the pain, because you have to know the level of the pain so that you can actually treat it properly. And it involves what kind of painkiller you are going to take or going to give according to the level of the pain. Okay, so two things. Good assessment of the pain and the appropriate treatment. This is really important. And I'm going to touch on why this is not being done and as a result that pain management is actually suboptimal. Now, assessment of pain, I'm just trying to see if I can actually do that while talking to you. Okay. Now, the assessment of pain it's very, very simple. As I said in my previous video, the patient comes in, he has pain. And by the way, I'm going to take pain as pain, not to divide into say chest pain or headache or abdominal pain, because pains in other situations might the treatment might be different in a way that you might need to do something else. Like in chest pain, of course, severe chest pain, severe angina, you need to give narcotic, but you need to give some vasodilators, GTN or something like that. So I'm going to take pain as an abstract, that the pain, the patient complaining of pain. So please just like follow me with this one, because it is important. Now the patient comes in, okay, gets in there and said, "Doctor, I have pain." As I said, whatever pain is that. Then the next question you should ask, before you say the site of the pain, radiation, all this stuff, I'm sure all of you know that. But before that, because the patient comes in with pain, his main priority now is for his pain to be removed. And then he should know what the diagnosis and so on. So the next question when the patient complains of pain is, how much pain you're in? For me to know that, I will ask you that in a scale of 0 to 10, if 0 is no pain whatsoever, no pain at all, and 10 is the most severe pain you can ever imagine. Okay? So how much is your pain? And I think it's better to repeat that 2 or 3 times so that the patient really understands what you're talking about. So the patient will say, "Oh, my pain is 7. Fine. Then you should know what 7 means. Okay? So that when you know what 7 means, you know what the treatment is going to be. If the patient say 2, you know what 2 means and what the treatment is going to be. If the patient say 10, you know what 10 means and what the treatment is going to be. Okay? Do not think twice. Do not look at the patient and say he's comfortable or whatever. If the patient is not comfortable and he say his pain is 3 or 4, it is 3 or 4. Khalas. Don't go and think about it. So now we know that the pain level is 5, 6, 7, whatever it is. Now I will just move this camera a little bit so that you can see here. That's a numerical rating scale. Okay. So from 0 to 10. So 0 is no pain whatsoever. Okay. From 1 to 3 is mild pain. From 4 to 7 is moderate pain. And from 8 to 10 is severe pain. Okay. So 1 to 3 is mild. 4 to 7 is moderate. 8 to 10 is severe. Right. Okay. Now we come to the treatment. Of course, you have. I'm going to talk. I'm not going to talk about you examine the patient and the history, other history and stuff like this. So I'll come to that later. But now we are actually assessing the pain and giving the treatment for the pain. Okay. Now, mild pain from 1 to 3, you give the patient something like paracetamol. Okay. Or sometimes you ask the patient, your pain according to your scale is 3 and it is mild pain. Do you want me to give anything for it? Do you want me to give you anything for it? Some patient would say, I said, okay, I'm going to give you paracetamol, tablets. You take 2 tablets if he's an adult, and they will work in about 20 minutes to half an hour or more, and so on. Moderate pain, which is from 4 to 7, okay, from 4 to 7. Then for this, you give NSAIDs or you give a mild narcotic. By mild narcotic, normally people give Tramal, okay? But in most cases, NSAIDs or IV paracetamol. IV paracetamol you can give for moderate pain. Oral paracetamol you give for mild pain. Okay. Some people will say, well, you can give both. You can give NSAIDs and give IV paracetamol because they actually potentiate each other and so on. But in most cases, either is actually enough. You might need to give Tramal and so on because the range is from 4 to 7. So if it is 7 and 4, so if it is 7, obviously it is more nearer to severe pain, so you can give narcotic. This depends on your assessment, and each patient should be treated differently. If it is 4, is more towards the mild pain, so most probably NSAIDs or IV paracetamol will be enough, or even paracetamol will be enough if the patient is okay. Okay, from 8 to 10 is severe pain. And severe pain, you have to give a narcotic. Full stop. Nothing else. You have to give a narcotic. Even this in the WHO, I think it is one of the human rights. And the rights of humans is just their pain should be relieved. This is a human right. And you have to give a narcotic. Because it's severe, I will start from that one. Because it's severe and it's very bad pain, you have to give something which works quickly. Because the patient cannot wait for half an hour or 20 minutes or something like that. Somebody with a severe pain as gouty pain or renal colic or whatever. Okay, so you have to give a medicine which works very quickly. It should be very effective. Okay, to give something which works very quickly, it has to be given intravenously. You have to give it IV. Okay, now I myself, I prefer morphine. I never give pethidine. Some pethidine given for people who come with sickle cell disease, but morphine for me is number one. So morphine, the normal dose is 0.1 milligram per kilogram, but most people actually take 10 milligram because the ampoule has 10 milligrams, and you dilute that in 10 mils of water. Okay, and you titrate it. Titrate, that means you give say 3 or 4 milligrams first and then stop. Okay, wait and see the reaction of the patient. If the patient says the pain is getting less, then obviously you stop and see. If the patient says the pain is still there in about 5 minutes or so, then you give another 1 milligram. You give by increment of 1 milligram. Okay. Normally, in most circumstances, the pain will be removed by the morphine. Okay. But you have to give morphine. Please do not give anything else. If you give morphine, the pain is not enough after the 10 milligram, then you can give IV paracetamol or NSAIDs. As I said, they potentiate each other, and that the effect will be more. But narcotic, IV narcotic should be the treatment of severe pain. I also use fentanyl, which is more powerful than morphine. And the good thing about fentanyl is that it does not actually lower the blood pressure. So if somebody come in severe pain and his blood pressure is low, if you give morphine, then obviously the blood pressure will be lower. But of course, you have to give IV fluids and so on. But fentanyl does not actually lower the blood pressure, so you can give that. So narcotic IV for severe pain. Please, this should be written in stone. You should remember it all the time. Now, I'm not going to talk a lot about the moderate and mild pain because, as I said, you just give what I told you before. Now, why people are not actually giving morphine for severe pain? They don't. And when I went to work in Dubai first time, nobody gives morphine at all, and people with severe pain like actually suffering a lot. And when I started giving morphine a lot, actually they called me in the Department of Health and they told me, look, yeah, that's really very serious. You are abusing narcotics and stuff like that. And we will give you a couple of weeks. And if this thing is continuing, of course, we can take action. But in the end, I actually convinced them. And now morphine is given there all the time. Not only that, I actually introduced with the ambulance people, introduced morphine to be actually to be in the ambulance. So if somebody is being collected from home or from the street, something like that, in severe pain, they can give him morphine, and I'm very happy about that. Now, why don't people give morphine? That's strange, isn't it? There is something called opiophobia. People just are afraid to give morphine for many reasons. One of them is that it has severe side effects. It can actually stop you breathing. Yeah, fine. The patient in the hospital has severe pain, has to be given morphine, and when you give morphine, you know what the side effects are. If there is any respiratory depression, you know what to give. You can give the antidote, naloxone or whatever. Okay. It happens to me. I gave a patient 2 milligrams of morphine and he stopped breathing completely. So we need to give naloxone, we need to back him and so on and so forth. But so what? Nobody should die in hospital because he has given morphine and he stopped breathing and there is a doctor there who should know what to do. That's number one. So that people are saying that it has severe side effects. The second thing is the regulations of the country. Sometimes if you give morphine, that's what happened to me. If you give morphine, then that's not good. How can you give morphine to patients in the emergency or whatever, or in the ward? The third thing, which is actually in the minds of some people, is that if you give morphine, sometimes people develop addiction. That's very strange. I mean, it's really something which is out of this world. How can you develop addiction from one dose? Sometimes they do, but it is very rare. And actually, I read a paper which is coming out of a burn unit, and pain units, they use morphine just like water. Because everybody is in severe pain all the time, they need their dressing to be changed, which is painful. They give morphine and so on. And they actually recorded about 15,000 patients, something like that, over a few years, and only 0.01 or something, a very, very small number actually became addicts. But of course, this should not stop you from actually prescribing morphine. So please, severe pain, IV narcotic, and I said I prefer morphine. I never give pethidine for 2 reasons. First of all, pethidine you give IM. It's recommended to give IM, and if you give IM, you have to give the whole dose. You cannot titrate it as you titrate morphine through the cannula. Number one. Number two, it is actually, if it causes respiratory depression, I found that it is more difficult to reverse. If you give naloxone, sometimes it doesn't work. Okay? And if it doesn't work, then obviously you have to do other things. But in morphine case, if you give naloxone, then that's the end of the matter. Morphine and pethidine, both of them cause constipation, respiratory depression, and so on and so forth. Pethidine, if the patient is on monoamine oxidase inhibitor, then that's a huge problem. I don't know if monoamine oxidase inhibitors are used anymore or not, but that's the other. But the main thing is that it has to be given the full dose IM. For pethidine, you cannot titrate it, which is a big drawback. So morphine is your man. I am a morphine man myself. Oh, I don't take it. I'm just give it to people with severe pain. What else? Fentanyl, of course, is narcotic as well, can cause the same problems. Fentanyl is, as I said, is a lot more potent than morphine. But if you go to many emergency departments, you don't see morphine. You don't see fentanyl there. I introduced it because, as I said, some people with low blood pressure can be given fentanyl to control their pain without worrying about lowering the blood pressure. Okay. So I hope that's clear enough. Now we cannot actually finish the opiate treatment of pain before we talk about drug-seeking patients. I'm sure all of you have experience with people who are addicts and they come to the hospital only to get morphine and then go. Okay. To start with, I'll think, always give the patient the benefit of the doubt. Do not assume that this patient is drug addict or drug-seeking patient. He might have a genuine complaint, so don't dismiss him out of hand. Even if you know that this guy is actually a drug addict, drug addicts, like all of us, can have organic disease. They can come with a medical problem. But to know them, first of all, they are very clever people. They're really very clever. They can actually, and they know a bit about diseases and so on and so forth. So the presentation, they come and they make a drama. Either they're in severe pain, they roll on the floor, they shout, and so on, and so very abusive at times, and so on. So they make a drama. That's number one. Number two, they tell you that they have this pain, back pain, whatever it is, and they have taken everything else, and they're still in pain. Or they tell you they're actually allergic to everything else, Voltaren, everything, NSAIDs, you name it, they're allergic to, so you cannot give them. The third thing, which most of them do, that they come with a report written by somebody saying that this patient is suffering from, and they choose diseases which you cannot actually check on the spot. Like they come with cases like familial Mediterranean fever, sickle cell anemia, and something funny like that, which you don't do the test just for the sake of excluding it. So that's the one. The fourth thing, which is really important, that okay, they'll convince you that they have this whatever, and you take them and you give them the morphine and whatever. Immediately after you finish giving them the morphine, they jump out of the bed and they walk out. That will not happen with somebody who has a medical condition, with a clinical case. So that's that three things or four things. After you identify them, you have to make a record, and you have to make it in a certain book that this patient is an addict. And of course, when they come again, you sit them, you take full history, as I said, give them the benefit of the doubt, and don't miss anything, and don't actually dismiss them out of hand. You have to treat them as any other patient. Take history, do clinical examination, whatever. Okay. So I think I hope you agree with me with all this. And I, as I said before, I'm very passionate about this because I had some severe pain myself, and it is really, I broke my scapula, fell off that bike and stuff, and it's severe pain, and I'm not crying or anything like that, but I'm in severe pain, and they keep giving me this Voltaren and stuff like that, and I suffered for maybe a couple of hours, and they sent me to X-ray. I still in severe pain. Okay, now I think that's enough because that's like 22 seconds. And the next talk will be about different kinds of pain, like abdominal pain. Mostly I'll talk about. Chest pain, I just touch on it. The abdominal pain is the one which I'm going to talk about next time. So until that time, I wish you all the best. I hope you keep well. And until I see you again, goodbye, cheerio, and hasta luego.